Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. I'm Dr. Brian Kaufman, co-founder, executive vice president, and the chief medical officer of the nonprofit CLL Society, and a retired family doctor, and also a CLL patient myself. And I would like to welcome you all to today's events. We are joined by Christina Russomanno. She's a nurse practitioner in the leukemia service at Columbia University Irving Medical Center. Before Christina presents on current CLL treatments, Robin Brundle, registered nurse and the director of our scientific affairs and research for the CLL Society, will share our latest resource, the Medicine Cabinet. You're really going to like this. Now we welcome Robin Brumble.
Hello, everyone. My name is Robin Brumble, and I am the Director of Scientific Affairs and Research at CLL Society. I'm going to review the CLL Medicine Cabinet that is now available on CLL Society's website. The CLL Medicine Cabinet is a place where anyone can go to access easy-to-understand information about each of the most common drugs used to treat CLL and SLL. The Medicine Cabinet contains printable, non-branded information sheets for each medication, and it includes links to other helpful resources that I'm going to go through in a little more detail. I'm going to very briefly go through how to navigate through the Medicine Cabinet and provide some screenshots. The easiest way to find the Medicine Cabinet is to go to CLL Society's homepage of cllsociety.org and scroll down towards to the bottom of the page. You will see within our Fast Find section, there is a teal colored box that says Medicine Cabinet. If you click on that, it will take you directly to where you need to be. Here we see what the CLL Medicine Cabinet looks like. We have included some information about the different things you and your healthcare provider will be considering when it comes time to choosing the treatment that might be best for you. On this page, you will also notice that there are pictures of medications within the cabinet. There are two ways to view these medications. Whichever medication you would like to view, you can either click on directly within the medicine bottle, or there are teal colored links to each medication's name underneath the medication cabinet visual that will also allow you to navigate to the same place. After you click on the name of the medication that you would like to view, and in this case, I'm just using ibrutinib as an example, it will take you to a page that allows you to have a quick glance to read through a 2-page medication information sheet. Then you will see 4 blue navigation buttons off to the right side of the medication sheet. The medication sheets were designed to include information about dosing, how to take the medication. They discuss some common side effects, provide some tips on how to work through some of those most common side effects, discuss reasons to talk to your healthcare provider, and they review some special considerations about the drug. If you would like to print out a copy of the medication sheet, you can do this by clicking on the top button that says Download and Print this medication sheet. If you click on the second button down that says Additional CLL Society Articles, this will scan CLL Society's website and provide you a quick list of all information that CLL Society has ever published on that specific medication. If you click on the third blue button down that says Financial Resources, you will be led to a web page that will allow you to read about how to obtain financial assistance if needed for this medication. We hope you will find the medicine cabinet helpful in learning more about the most common drugs used to treat CLL and SLL. Now I would like to introduce our speaker, Christina Russomanno.
Hello, thank you for having me today. My name is Christina and I'm a nurse practitioner working almost exclusively with CLL and SLL patients for the past 11 years. I also work directly with a CLL expert physician. I'm really happy to be here today to discuss current treatments in CLL. I do realize that viewers here are at different places. Some of you are newly diagnosed. Some of you have been diagnosed for years and have had prior therapies. So because of this, I really do want to keep this very simple and straightforward to provide information without overwhelming anyone. So we're going to start with the CLL SLL medicine cabinet, understanding your available treatment options. So I need therapy. How did I get here? So there's a couple ways you could be here today. So very rarely you are diagnosed with CLL and you are told you need treatment right up front. And so though this is rare, this can be completely overwhelming because not only are you wrapping your head around a diagnosis of CLL or SLL, but now you're being told that you actually need some therapy. You may not even have any symptoms, but there are these guidelines that most oncologists follow when it comes to treating patients. And what they're telling you is that you meet criteria for some therapy. Others are in watch and wait or active surveillance or active monitoring. You have been diagnosed some time ago. You have not met criteria for treatment. And so you've been monitored probably with some physical exams and some blood work every X amount of months. Maybe now you're starting to progress and you're starting to be interested in what your therapy options can be. And I do like to tell people in the watch and wait or active surveillance period that this is not a time when you're actually being ignored. This is a time when you're being empowered. And so during this time, you really should focus on educating yourself on your disease. You have the time, and there are fantastic resources out there via CLL Society, via other societies that focus on leukemias, where you can find really simplified information, and it's categorized by topic. So you can look up whatever you're interested in. This is also a really good time to find your support system. So that's your family, your friends. These are the people who you're going to rely on if you need a ride, you need someone to come to your appointment, you don't feel well. And I also, in this support system category, really do recommend that you connect with a support group, a CLL related support group. These, you don't have to participate actively. You don't have to be a leader. You can be quietly in the background. There is room for all comers, but these are people who are in the same place you are or have been where you are. And sometimes their support is very, very important because they know how you feel and you know how they feel. Healthcare maintenance is really important during this time. This is when you have your normal health screenings performed. So these are the things that would be recommended whether you had CLL or not. So your colonoscopy, your mammogram, dermatologic skin screenings. We know that CLL patients have a higher risk of secondary cancers, especially skin and colon cancers. So if you have your screenings and things are caught early and removed, then that's the end of it. But if you don't have your screenings, things there could grow. So we do strongly recommend that you follow the health guidance and you get your screenings. We also recommend during this time that you receive your vaccinations. We know that you are at a higher risk for infection. You are immunocompromised at baseline. And so we do recommend giving yourself the best chance. And that's why we recommend vaccinations. We do not guarantee, obviously, that you will not get sick, but we do want you to have the best chance to fight off anything that might be coming. And we also recommend those vaccines for your immediate family members or people you will be around. And a reminder, no live vaccines in CLL, SLL patients. And then another option you have is to meet with a CLL expert for a second opinion during this time. It does not mean you do not like your oncologist or your, whoever is following your CLL or SLL. It's just another person to touch base with, maybe for more information or some clarity. People meet with CLL experts once, they meet with them twice a year. They meet with them when there's a treatment change because they just want another opinion. And so that's also an option for you. And you can find a CLL expert on your own and make an appointment, or you can seek an expert opinion via the CLL Society website. So when is it time to start therapy? This is a very overwhelming slide, so we're going to break this down. So progressive bone marrow failure with worsening anemia and or platelet count. So what does that mean? So basically, all your cell lines are made inside your bone marrow, which is inside your larger bones. This is where you make your white blood cells, your red blood cells and your platelets, which all have their own functions. In CLL, when your disease is acting up and you're over proliferating these white blood cells or these lymphocytes in the bone marrow, it crowds out the bone marrow. So these other cell lines, like your red blood cells and your platelets, can't be made, and those numbers start to drop. How do we know this? We draw your blood and we do a complete blood count when you come into the office, and we can see that your hemoglobin is lower and your platelet count is lower. When your red blood cell count is lower or your hemoglobin is lower, you're considered to be anemic. And symptoms of this can be fatigue, headaches, palpitations. You just might feel that overwhelming just lack of energy. And if your platelet count is low, we know platelets are responsible for clotting. You might note that you bruise easier, you bleed, your cuts don't heal as quickly. Okay, so that's why these become concerning, is if these numbers start to drop, it can leave you in an unsafe position. Massive or progressive splenomegaly or lymphadenopathy. So what that is your spleen is your largest lymph organ. It sits in your left upper abdomen, and it can grow. And when it grows, it can cause some pressure in the area. It can push on your stomach. And when it pushes on your stomach, you won't be able to eat as much. You might have eaten a foot-long sub at one point, and now you can only eat a 6-inch sub. And so that's what happens when your spleen grows. And your lymph nodes, though not all CLL patients have lymph nodes you can feel, some patients do get very large lymph nodes. And when these lymph nodes grow enough that they restrict movement or they're compressing on something, that can be an indication for treatment. Progressive lymphocytosis, or a lymphocyte doubling time of less than 6 months. This is just general, and this is a way we kind of watch the tempo of your disease. There are no set numbers here. Just, if your absolute lymphocyte count is doubling in less than 6 months, we're going to watch you more closely. It means your disease is starting to act up. Symptomatic or functional extranodal involvement. So this is when your CLL is misbehaving. So it's outside of your blood and your lymph nodes now. It's affecting other parts of your body. So you might have some skin manifestations, maybe some lesions or a rash. Your kidney function might be off a little bit, and we think that the CLL is the reason for this. You might have some fluid in your lungs. We test and we see that it's CLL. And these are just some vague examples. But that would be an indication for treatment. Symptoms, so significant fatigue, which is limiting your activity, night sweats, weight loss, fevers of at least 2 weeks without infection. These are considered to be B symptoms. That's what we call these. So if you're having some of these, it could be an indication for treatment. Autoimmune hemolytic anemia and or immune thrombocytopenia purpura. So what these are autoimmune phenomena. They're related to the CLL, but they're treated differently. And so in autoimmune hemolytic anemia, you're making red blood cells, but once they go into the peripheral blood, you're destroying them. And with ITP, or immune thrombocytopenia purpura, it's the same thing, except it's the platelets. And so these phenomena are treated usually with steroids or a monoclonal antibody like rituximab. But if for some reason you are not responding to that treatment, then we have to treat the underlying cause, which is the CLL. Considerations prior to treatment. So your providers will ensure that there is not some other reason for any of these symptoms before they start. So again, anemia, where your red blood cell count is low, or thrombocytopenia, where your platelet count is low. They're going to make sure there's no other reason for this. So you don't have an iron deficiency anemia. You don't have any kind of bleeding in your GI tract. Some people do have a history of GI bleeds or esophageal varices that can bleed. Again, we'll assess for these autoimmune phenomena, the autoimmune hemolytic anemia and ITP. And then when it comes to symptomatic disease or rapidly progressive disease, if your B symptoms are very dramatic, right? So those are the ones we talked about that are overwhelming fatigue or weight loss or night sweats. So if those are kind of overwhelming and sudden onset and very aggressive, and or your disease seems to be rapidly progressing, because we know CLL doesn't normally rapidly progress. So if all of a sudden you have a lymph node that was the size of a pea, and now that lymph node is the size of a softball, or you have these other dramatic symptoms, then what we're going to want to do is just make sure you haven't what's called transformed into a more aggressive lymphoma. And the way we do that is we do a PET scan. And so, CT scans are usually the hallmark of monitoring CLL patients. But with a PET scan, what happens is we can kind of see which areas light up very hot. It's a different kind of scan. And so if the reading on the scan shows areas, rapidly dividing cells or suspicious areas light up brighter on these scans, and if they meet a certain criteria, We would then go in and biopsy that area just to ensure that there's not a high-grade lymphoma there, because that would be different treatment. So other factors to consider when choosing a new therapy, and these are the ones that are about the patient, right? This is about you. So your age, and this is not to be ageist, but there might be a difference in tolerance and ability to handle treatments based on someone, comparing someone who's 30 to someone who's 98. And so we do look at that when we consider therapy. Your specific disease markers, this is truly very important. We've all heard of test before you treat. If these markers are not tested at diagnosis, they should be done prior to treatment, specifically your FISH testing and your IgHV mutation status. So the reason we need these is because A, we can risk stratify your disease a little bit better. And B, we know that people with some of these higher risk markers, like a 17p deletion or a TP53 aberration, that they respond possibly better to some therapies than others, and other therapies will not work on them. So we really need to know what these markers are to give you the best options for treatment. Performance status. So are you a marathon runner? Are you just someone who works out once in a while, or are you bedbound? Can you not walk? So some of this can impact how you can get to your visits and what you can handle. Your comorbidities. So what other medical conditions do you have? Do you have cardiac disease? Have you had a stroke? Are you someone who bleeds a lot? We need to know this because it might alter the treatment we recommend and or alter how we give it to you. Your goals, this one's super important. There's kind of two ways to look at this. So there are some patients who feel that they just want to feel better. They want their symptoms under control. They want their blood counts to be safe, and they want to go on with their lives. They have a planned cruise. They want to travel Europe. And that's really what matters to them. There are other patients who really feel it's important to be on therapy as little as possible. They want a time-limited option. They want a treatment-free period. And some of those people also feel that they want undetectable, measurable residual disease, right? So they want someone, when they're done with their therapy, to check their blood work or their bone marrow and not be able to find their CLL. And so there's two schools of thought there usually. Your lifestyle matters. What are you responsible for? Are you someone who works 80 hours a week and you're the sole provider for your family and you can't miss work? Are you someone who's retired and you're quite flexible? So this is an important one. And your support system. Who is there for you? Is there someone there for you if you have frequent appointments to bring you back and forth? Is there someone there for you if you don't feel up to your grocery shopping? So these are all things that not only you need to consider when choosing therapy, but we need to consider for you when choosing therapy. These are the current treatment options in CLL. And this slide, again, is another one that's pretty overwhelming. I'm just going to show you this, but we're going to break this down in future slides. So targeted therapy, so what these are the new novel agents in CLL and the hallmark of therapy right now. So targeted therapy are cancer treatments that target a particular area, protein, receptor, pathway in CLL cells. Very, very, very specific drugs. They have a specific way of working. They do not target your healthy cells, and that limits side effects. So what do? Generally speaking, it depends on which one, but they block or turn off chemical signals. They can change proteins within the cancer cells. They stop making new blood vessels. They can trigger your immune system to kill the cancer cells, and they can carry toxins to the cancer cells to kill them. And so this is kind of why the targeted therapies are really specific and have become the hallmark, is because the lack of other side effects. So there's two main classes we're going to discuss here that have become the hallmark. The first are the Bruton's tyrosine kinase inhibitors, or BTK inhibitors. Okay, these inhibit BTK, which is very active in CLL, by interfering with signaling and preventing growth and survival of those CLL cells. BTK inhibitors are continuous therapy. They are taken every day. They are not time limited. This is like you taking your blood pressure medication every day or your thyroid medication every day. I tell people that if you are on this therapy every day for the rest of your life, that's a good thing, because that means you did not progress and you're tolerating it well. This can be given alone or in combination with a monoclonal antibody, which we'll talk about. And that's, whether or not it's combined is dependent on your specific CLL and your needs. Less office visits, less monitoring with this regimen. It's a little bit easier to handle. Again, the reason is that there is no risk of tumor lysis syndrome, or very little risk of tumor lysis syndrome with the BTK inhibitors. And so what tumor lysis syndrome is, it's the aggressive and rapid breakup of your cells. And so though that's a good thing that you want, you have to be able to monitor that appropriately. And so if these cells are dumping out their contents into your bloodstream, you're talking about, your phosphorus, your uric acid, your potassium. These are levels that we have to monitor and make sure stay safe so we do not hurt your kidneys. So that, though, the risk of tumor lysis is what kind of puts people in a more daunting monitoring schedule. And so with the BTK inhibitors, there is no tumor lysis, and therefore it's a little bit more lax with your office visits. The BTK inhibitors work very, very quickly peripherally on your lymph nodes and spleen. You will see improvement in days to weeks. They will melt away. Slower to work on the bone marrow. When we talk about undetectable measurable disease, much less likely to occur on a BTK inhibitor. It can take, and if it does happen, it can take years and years to occur. So if that's something that's important to you, that's not a common thing to be found with BTK inhibitors. And the good thing is they do work well with those with high-risk genomic features, such as deletion 17p. It's kind of the preferred regimen at this time for those with a deletion 17p. So examples of covalent BTK inhibitors, we have Imbruvica or ibrutinib, which was the first generation, first to market game changer drug. And then we have two second generation drugs. We have acalabrutinib, which is, or Calquence, and zanubrutinib Brukinsa. Most providers now who are prescribing BTK inhibitors are starting with the second generation just because of the improved side effect profile of those drugs. They're just tolerated a little bit better. That said, insurance does play a role here, and we know insurance can limit or decide kind of which their preferred drug in the class is. And the good thing is that all of these drugs actually do work. So it's not that if you have to take ibrutinib, that's wrong. And examples of non-covalent BTKs, so these are in clinical trials right now and are not currently approved in CLL, but hopefully soon. You have pirtobrutinib and nemtabrutinib. Those are two of them that are kind of being studied right now. And we've seen really great results in clinical trials so far. General side effects of BTK inhibitors, these are class side effects. So commonly when you start some joint and muscle pains, higher risk of infection, which we know, report any infectious symptoms to your providers. Diarrhea, I usually tell patients on onset, a couple episodes is fine. Profuse diarrhea is not. High blood pressure, there is a risk of developing high blood pressure or worsening high blood pressure when you're on these medications, and you may need to start antihypertensive medication. Higher risk of bleeding. We know these drugs function a little bit like an aspirin and thin the blood. You will probably bruise easier. You may bleed a little bit easier. We want you to avoid other drugs that can increase your risk of bleeding, such as ibuprofen, Motrin, aspirin. And we also need to know before any invasive procedures, because we would need to hold the drug X amount of days before and X amount of days after, just to ensure that during the procedure you didn't have any extensive bleeding. Atrial fibrillation is a heart arrhythmia that is possible. Other important side effects, you can have some dermatologic changes. Besides some bruising, you can have some rashes, some fatigue. That usually gets better with time on treatment. Ventricular arrhythmia is very rare, and cytopenias, which is when your blood counts drop a little. Maybe they fall below what is considered to be a normal level. That would be your white blood cell count or your hemoglobin or your platelets. I do have to mention with the two second generation BTK inhibitors, zanubrutinib has a higher risk of neutropenia. So what neutropenia is when your absolute neutrophil count on your differential falls below a certain level, it just means your infection fighting cells are low. Because of that, you might need some growth factor, you might need a shot, but if it's persistent, you also might need a drug holiday and or a dose reduction. And acalabrutinib is associated with headaches early on. These are very responsive to Tylenol and caffeine and should get better with time on treatment. BCL2 inhibitors, this is the other class of novel agents that are the hallmark of therapy for CLL right now. There's only one BCL2 inhibitor that is approved right now, and that is venetoclax or Venclexta. There are others in clinical trial. What these do is they inhibit BCL2, which normally protects your cancer cells from dying. And BCL2 inhibitors or venetoclax, this is a time-limited therapy. So this is not continuous therapy like the BTK inhibitors. So upfront therapy, when you're newly diagnosed and you're taking initial therapy, it's used in combination with obinutuzumab, which is a monoclonal antibody, and for a total treatment time of 12 months. And then you get a treatment-free period. In the relapsed or refractory setting, so after your first line of therapy, you would get venetoclax in combination with rituximab for a total of 24 months, though both the monoclonal antibodies are only given for the first 6 months in both regimens. With venetoclax, the drug ramp up is over 5 weeks with very close monitoring. And so the way this regimen is usually given is they start with the monoclonal antibody and they use that monoclonal antibody to kind of debulk a little bit in the beginning to bring your disease burden down. Because both the monoclonal antibodies and venetoclax have a high risk of tumor lysis syndrome. And so even patients who are considered to be super high risk for tumor lysis syndrome, and those are patients with big bulky lymph nodes or a higher white blood cell count, those patients might actually have to be hospitalized for initiation of this just to ensure that their labs are checked often, they're getting constant hydration, and there's no aggressive tumor lysis. And so, and then again, both drugs that are used in these combinations can do this. And so, you know, versus the BTK inhibitors where we said there's no tumor lysis syndrome, with this regimen there is, and there's the possibility of it. And so therefore, the office visits are more frequent, the lab checks are more frequent. It's much more daunting early on. Now, when you say daunting early on, that's true for the first maybe 8-9 weeks. But then once you are established and your venetoclax dose has been ramped up over the 5 weeks, you go back home and you're taking your pills every day like you're supposed to, and you come in for your infusions. So it does calm down. With this regimen, there is a possibility of undetectable measurable residual disease. This is important to some patients. It happens much quicker than it could possibly happen with the BTK inhibitors. And there's a possibility of retreatment if relapse greater than 24 to 36 months. Patients do re-respond to this regimen. I'm going to kind of skim through the PI3K inhibitors. These are also targeted therapies. They are FDA approved in relapsed CLL or refractory CLL. Their use has been limited based on their side effects. They have a high risk of infection, and we've had major gastrointestinal issues with these, colitis, diarrheas, hepatotoxicity, which is just injury to your liver. And so the use of these drugs has been very limited. I cannot say there's not a time and a place for these drugs. There might be a time where these drugs can be helpful, and there have been many patients who have tolerated them quite fine, but you can see the percentages here. So we've had a little bit of difficulty with these drugs. Monoclonal antibodies. So monoclonal antibodies have been a hallmark of treatment for a very, very long time. They're used in other medical issues. So they're used in neurologic disorders. They can be used in rheumatologic disorders. They're generally speaking well tolerated. They're a type of immunotherapy, but also target a specific protein. They're man-made versions of immune system proteins or antibodies. And so they attach to a specific target. And in CLL, this protein is CD20, and it's found on the surface of your B lymphocytes. And so they help your immune system react to and destroy cancer cells. They're given via infusion over about 3 to 4 hours in an infusion center. One of the drugs, rituximab, can actually be given subcutaneous later on. They can be used alone or in combination. So, you know, someone who needs some gentle therapy, maybe has a lot of comorbidities, as on the older side, you can control disease with a monoclonal antibody. But as we know, they're used in combination with venetoclax, and they can be used in combination with your BTK inhibitors. Common side effects, infusion reactions are the most common. You will be pre-medicated if you're to receive one of these, usually with Tylenol, an antihistamine like Benadryl, and possibly even some steroids to prevent a reaction. If you do have a reaction, the infusion will be stopped, and then they will give you some medications to make whatever symptoms you're having go away. And most patients, I would say greater than 90%, can restart their monoclonal antibody with no further reaction. You can have fevers, chills, low blood counts, infections. There's also an impaired antibody response to vaccines when you're receiving this because of the depletion of your B cells. And so you are unable to make antibodies. So vaccines will not hurt you, but you will not be able to mount the appropriate response. And so there's really not that much point to receiving vaccines. We usually say wait at least 6 months from your last dose of your monoclonal antibody. And commonly used in CLL, rituximab, which is Rituxan and has multiple brand names, and obinutuzumab, which is Gazyva. Combination. So we've kind of talked about the first bullet point, targeted therapy and a monoclonal antibody. This is super common. This is using a BTK inhibitor with a monoclonal antibody and or venetoclax with a monoclonal antibody. 2 novel agents, BTK inhibitor and venetoclax. We call this a doublet therapy. This is time limited. It is not approved in the United States. It is approved in Europe. And in the United States, we're looking at these in clinical trials at this time. And then you have the 2 novel agents. So now you're going to take your BTK inhibitor, your venetoclax, and you're going to add a monoclonal antibody. Now you have 3 things going for you. We call this triplet therapy. This is only available in clinical trials right now. And thus far, there hasn't been enough evidence to say that there's any benefit of triplets over doublets. And so, until there's proof of extended progression-free survival or overall survival in CLL patients, this is not going to be recommended. So traditional chemotherapy, chemoimmunotherapy in CLL, this is given via intravenous infusion in cycles, usually every 21 to 28 days for 6 total cycles. Chemoimmunotherapy does target all quickly dividing cells, not just your cancer cells. And because of this, it's pretty toxic, and the side effects are your cancer treatment stereotypes, right? Your nausea, vomiting, your hair loss, your low blood counts, your fatigue, your infections, your loss of appetite, that pale, sick person sitting in an infusion chair. There's really less to no role in CLL these days. It was the hallmark of therapy before these novel agents started coming around. But we know that chemoimmunotherapy does not work, especially in those with high-risk genomic features such as 17p or TP53 aberration or an unmutated IGHV. And this is, again, another reason that these need to be checked for before you initiate therapy. Again, I will not sit here and say there's not a time and a place for every option. If you were to go for a bone marrow transplant or you were to receive CAR T cell therapy, PrEP is actually traditional chemotherapy for those. And the most common regimens used are bendamustine and rituximab, known as BR, or fludarabine, cyclophosphamide, and rituximab, which is FCR. We do also know that there's still a lot of chemotherapy used in the community setting. And so this is something a lot of us are working to educate on and introduce novel agents. So bone marrow transplant in CLL, this is the IV infusion of blood-forming stem cells collected from bone marrow, peripheral blood, or umbilical cord blood with the goal of cure. Allogenic, so it means it's donated by another person. You do not get your own cells. This involves rigorous testing not only of you, but of all potential donors to make sure that someone that is found to donate for you is compatible or as compatible as humanly possible. You will receive conditioning chemotherapy to wipe out your bone marrow with the hopes that when this is infused into you, the cells are infused into you, this becomes your new bone marrow, this becomes your new immune system. It involves an extensive hospital stay and very close monitoring. There are lots of possible side effects here. This is not something to go into lightly. High risk of infection. We've taken away your immune system, low blood counts. We've wiped out your bone marrow. Bleeding, graft versus host. Graft versus host is when, the cells that you've received are kind of attacking you in some capacity. And so you might have, some skin disorder, or you might have some GI side effects, and even death. Whenever you consult with a transplant physician, they will tell you that there is a chance that you could die. This is considered in relapsed refractory disease. It's especially for those running out of options or those who have transformed to Richter syndrome or transformed disease. When CLL transforms into this aggressive lymphoma, you would be treated with chemotherapy or some kind of therapy, and then the goal would be a bone marrow transplant or CAR T cell therapy. So again, not something to go into lightly, not something that is considered in frontline. Chimeric antigen receptor or CAR T cell therapy. So this is immunotherapy that uses cells instead of drugs to fight CLL, and this is kind of the new wave, the new thing. Patients' own T cells are harvested. So what they do is they'll put a catheter in you, and they'll take out your blood, and they'll steal your T lymphocytes from you, and then they'll give you everything back. And then they'll take your T lymphocytes over to the lab, and they will train them to attack your CLL. They will grow them, and they will give them back to you to be reinfused. You will receive PrEP chemo before that as well. And there's also some possible side effects of this. This is also not a benign procedure. So risk of cytokine release syndrome. This is an aggressive inflammatory response. Fevers, chills, you can just feel really, really sick. You can have some organ damage. You can wind up in the intensive care unit. And neurotoxicity, you can have some neurologic side effects, some word finding difficulty, some neurologic changes, possibly even some seizures. This is not currently approved in CLL, but it is available via clinical trials, and it also is not something that is given upfront. This is something that's given once you're running out of options or with more aggressive disease. Clinical trials. So this is access to the newest and most advanced treatments before they are widely available. Their clinical trials are what have led us to these amazing new novel and targeted agents. It's because of the participation of the patients that we now know that these drugs work better than traditional chemoimmunotherapy. If it wasn't for patients on trials, we would have no idea. And so what clinical trials are not to make you a guinea pig. Clinical trials are there to test new drugs that we are hopeful about, and or combination of drugs, maybe drugs that we already use and we want to see if putting them together makes anything better. Important drugs currently being used in trials. We have BTK degraders. So these degrade BTK instead of just inhibiting it, like the BTK inhibitors. And what this does, it can allow us to overcome some of the mutations that you may develop when you're on these BTK inhibitors that make you refractory or unable to take them anymore. BiTEs or bispecifics. So these work by attaching to two different antigens on separate cells, one CLL cell and one on a T lymphocyte, and that leads to destruction of the CLL. And this is an example of this is EPCOR, and those of you are probably following Dr. Kaufman's journey with EPCOR. This is a bispecific. There's also new targets and new combinations all the time that we're putting together and we're investigating. And so this is the importance of clinical trials. Clinical trials can be offered to you at any time during your treatment, upfront, relapsed, refractory. Okay, so they're always there. If you're interested in clinical trials and where you are being treated does not have them, you might want to investigate, more academic medical centers in the area. They would be more likely to have clinical trials. So in conclusion, be an advocate for yourself when it comes to treatment. I firmly believe that, your specific CLL should be explained to you, considering all factors of who you are as a person, and not only that, the results of blood testing. If you have questions, concerns about treatment options, I do recommend that you do seek a second opinion. It is not an insult to anybody. It is your life, and you should have all the information that you deserve. There is very little or to no role for chemoimmunotherapy and CLL these days. The novel agents are the mainstay of therapy, and we talked about those, briefly, but those are your BTK inhibitors and your BCL2 inhibitor, venetoclax. Most patients will see more than one therapy in their lives. I stress this because if all things are even and you're deciding on upfront therapy and you're stressed out about which one to pick, more than likely you will see both regimens at some point. And so therefore, I like to tell people you really can't make a life-altering decision here by choosing the wrong one. And then you really need to rely on your care team as an advanced practice provider and a nurse. I would rather hear from you early if you're having issues or you're confused or you're just not sure of something. Don't be a hero. You're not annoying anyone. You need to call the office. And so I'd rather hear from you then before you feel very ill. So I want to thank you for having me. I hope I was able to provide a brief and general overview of treatment in CLL. We could technically spend hours talking about each drug class, but I hope this provided a bit of basic information for you. And thanks again so much for having me.
So Christina Russomanno is here to answer your questions. And there are so many questions that there's absolutely no way we're going to get to all of them. So I'm going to say up front, if you've asked a question and we didn't get to it, send it to Ask the Expert email that we'll share with you at the end of this, because we have a ridiculous number of questions. So, and thanks to everyone who submitted a question in advance. So I'm going to start with the people who put the questions in advance to encourage you in the future to do the same. So what seems like a basic question, Christina, but this comes up often, and it's really not that basic, is talk to us about CLL versus SLL. Or the therapies that you're talking about apply only to CLL? Do they apply to SLL? What's the difference? Is it something that patients should be aware of? So explain what the difference is between SLL and CLL and what you think of as a clinician. Does it make a difference in choosing treatment?
Yes, thank you, Brian. Yes, so generally speaking, we consider CLL and SLL to be the same disease, but there are some differences. So SLL is actually exclusive to the lymph nodes, whereas with CLL, we can see it in your bloodstream and in the bone marrow. And so to be diagnosed with CLL, you have to have an absolute lymphocyte count greater than 5,000. When you have SLL and it's confined to your lymph nodes, you haven't met that criteria yet. but your SLL may eventually be CLL. And these diseases are treated the same. We do use, if you need treatment, you have the same options, whether you are diagnosed with CLL or SLL.
All right, let's move on to the next question. You talked about immunotherapies, and you talked about the monoclonal antibodies and also CAR T and bispecifics you touched on too. There are some unusual side effects from immunotherapies that are different than other therapies. Can you talk to us a little bit about those and how those are managed?
Yeah, so the most common, obviously, immunotherapy we use in CLL and SLL are the monoclonal antibodies. These are, infusions that last 3 to 4 hours, where there are common reactions to the infusions themselves. Patients are warned that they can have infusion reactions. They are warned that they can develop fevers, chills, infections. We know that there can be odd things like reactivation of hepatitis or other, considered to be rare side effects. As far as these other therapies, the bispecifics, et cetera, we know you can have some kind of nervous system involvement. You can have pretty much, if you look at the side effects of the bispecifics, you can pretty much have anything. But nervous system, joint, back pain, swelling, headaches. So I don't know if I would call them strange or different side effects, but I would call them extensive or sometimes maybe more critical side effects that have to be monitored more carefully or in a more controlled setting.
You mentioned several combinations, but one combination that some patients are on is ibrutinib and venetoclax. And my understanding is while this is approved in Europe and other places, it is not approved in the US, but it's still being used. Could you comment on that combination?
Yeah, so, medicine is an art. And we like to say this a lot. These providers are looking out for your best interests. A lot of patients with high risk features or patients who might be slowly starting to progress on one agent, they might add a second agent to try to help. There's a synergistic effect there. So sometimes patients do better when both are used together. And they've really shown that despite 2 different drugs having different side effect profiles, there actually hasn't been much toxicity or much trouble managing the side effects of the 2 different drugs together.
The venetoclax and obinutuzumab is a very commonly used combination. A lot of people have difficulty with that first dose of obinutuzumab. And a patient is asking, is there anything they can do before they show up at clinic to get this infusion, concerned that they're going to have this infusion reaction? Is there anything that they can do that day before in terms of what they eat, what they do, anything that the patient can do? Patients are always interested in is what can I do to help,
I wish you could do more, honestly. I think this one's on us. But, being well rested, being confident, coming in, I always say bring some snacks. It's a long infusion. Bring things that will make you comfortable during your infusion, any kind of entertainment. As far as mitigating possible infusion reactions, it is a reasonable concern. It is our responsibility to pre-medicate you appropriately. Some patients, if we're really concerned about a reaction, we will even give them some steroids starting a couple days before obinutuzumab to really try to prevent infusion reactions. But that's a discussion with your provider, but you will be pre-medicated. And all I can say is, come with whatever would make you the most comfortable for a long infusion.
One patient complained about a specific complaint, which is not unusual with ibrutinib, and that's dry eyes. And wondering if you have any tricks on that. They're seeing an ophthalmologist, they're getting therapies. How do you respond to that if the patient develops? And this can be debilitating, the dry eye.
Yeah. Again, obviously the first thing to do is make sure that there is not another reason for this. But if followed by an ophthalmologist, I'm going to assume that other possible causes have been ruled out. We do know, I think it's about 17% of patients in one study develop dry eye on ibrutinib. And Restasis and those rewetting drops are great. Only if it's enough. You can switch to other drugs within the class. You can try a drug holiday to see if it gets better. But really, if it doesn't and you need therapy and you're staying on your therapy, only the patient themselves knows if this is something that's tolerable or if this is something where they might want to consider other therapy.
People in other therapies, like in treating other cancers like CML, can stop their long-term tyrosine kinase inhibitors, and BTK is a tyrosine kinase inhibitors. What about drug holidays with drugs like ibrutinib, acalabrutinib, zanubrutinib? And what about stopping these drugs if you reach low levels of disease?
So again, at this time, these are considered to be continuous therapies that are not stopped. And the reason is that most patients on these drugs will still have some sort of detectable disease, even years in. We know there's a very low chance of undetectable, measurable disease. That said, in testing these combinations, they are looking at when the best time to stop is. And so eventually we believe this will trickle down to having a better idea of when and if we can stop these continuous therapies at some point for our patients.
And let me just add to that if you're going to have something where you have to go off the drug, let's say you're going to have a hernia repaired and you have to go off the drug because of the bleeding risk. And you're taking a forced drug. I wouldn't call it a holiday having a hernia, but you're going off of the drug for a while. It seems fine. The study after studies have shown that patients do well. They can be off the drug for a while and start again. There are a small percentage of patients when they take the drug, when they stop the drug, especially early on, the CLL will flare and come back more aggressively. The nodes will swell fast. There's that redistribution. When we start, the nodes shrink rapidly, and sometimes the white count, the lymphocyte count, will actually go up because the cells are leaving the lymph nodes and entering the blood. The reverse happens when you stop it, and it can be very scary. And sometimes we even have to treat that with steroids and other drugs. So that can happen, but that's usually in the first year or so of therapy. Once the disease burden is lower, that doesn't happen. But you can't stop the drug. And at the conference that you and I were just at IWCLL, there was some data presented out of Leeds in the United Kingdom, looking at patients who'd been on ibrutinib for 6 years. And it was very encouraging that most of these patients, and it wasn't followed out that long, it was only followed for a year, but most of these patients did very well after a year. Some of them, disease actually decreased off the ibrutinib. This was not what I would have expected the result to have been. Many of them stayed stable, and some did progress. And that applied for all groups. The few people who had reached undetectable, measurable residual disease, as you pointed out, but also the people who had just very low amounts of disease, like 1%, but the ones who also had 1 to 10%, and even the ones who had more than 10% did quite well. So this is a new area that we're just on the edge of looking at, because the gospel has been you take these drugs until you progress or can't tolerate them. But the doctors at Leeds are saying, hey, maybe we can reassess this. Okay. There's a question, and you kind of touched on this. Can you stay on these drugs long-term, like zanubrutinib? Can you stay on long-term? And what if it stops working? Like if your BTK inhibitor stops working, what other options do you have?
So yes, you can stay. The goal is obviously at this point in time to stay on these drugs. So if you're taking zanubrutinib, for example, and the drug stops working, so we're talking about progressing, we're not talking about side effects, then of course there's other options for you. Usually what we would look at next would be time-limited therapy with a venetoclax-based regimen. So venetoclax plus rituximab would be used in second line. But there's also obviously some clinical trials out there that you would probably qualify for. But yes, there are definitely options after BTK therapy or zanubrutinib. And this is for progression of disease. Obviously, if it was just an intolerance issue, we would consider switching within class.
Yeah, and so if somebody had side effects on Xanu but was doing well, you might try acalabrutinib or even ibrutinib to see. What about dose reduction? Talk to us about that, because that's fairly commonly used in ibrutinib, and less so, I think, with the other 2 BTK inhibitors. But can you talk about that and what role that might play?
Yeah, so some patients who are having some significant side effects, we would consider, first we're really supposed to try to stop the drug for a period of time and just ensure that it actually is the drug. But there are other patients, we put them back on the drug, and then we can kind of dose reduce or fine tune the dosing of the drugs where it's working for you and your side effects are minimal to none. It's a lot easier with the daily dosing of ibrutinib than it is with the twice a day dosing of the other two. Those on ibrutinib could be either. But yes, it's not uncommon. We have a lot of patients who do quite well who are dose reduced. It doesn't mean that it's not going to work for you. Sometimes it's what we have to do to get you through.
You mentioned pirtobrutinib, and that might have been an answer to the other question too. If someone progressed, they could try pirtobrutinib. And you mentioned covalent, but and non-covalent. But can you talk us through what does covalent and non-covalent mean, and what is the practical significance of that from a patient? Also, pirtobrutinib is not approved in CLL, but have you had trouble as a clinician using it off-label now that it's on the NCCN guidelines?
We have not, luckily. We have actually been able to get the drug, especially in those who are having, who are reading as accelerated CLL, not quite a Richter's transformation, but an accelerated, and even in Richter's transformation. We've had luck getting the drug. We don't have that many patients on it. But yeah, so your covalent BTKs are the ones we well know. These non-covalent BTKs are considered to be reversible. They can be used for patients who have developed mutations on the covalent BTK inhibitors, which is amazing because they're kind of the same drug, but they overcome some of this resistance, which gives you another option in the drug class. And again, we are waiting for these to be approved in CLL, waited with bated breath, but so far we've been lucky to be able to get them for patients who have disease that is getting a little bit more aggressive.
And dealing with the covalent versus non-covalent, can you explain what that means in terms of how the resistance develops, how they bind? Can you just walk us through that in a patient-friendly way?
Yeah, so with the covalent BTK inhibitors, unfortunately, you can over time develop these resistance mutations, which we can test for with certain special testing, I guess, special testing that's usually a little bit more extensive. And then when we move to the non-covalent BTKs, they overcome these mutations. And so therefore they still work despite having these mutations. I'm trying to simplify this as much as I can. They still work despite you having these mutations. So it's another option for you in the same drug class. And it, again, it just gives you kind of like another option. There's a couple of different mutations like PCL gamma and BTK to overcome these, I guess, within the same drug class. It's kind of repeating myself, but I'm trying to simplify it as much as possible.
And the chemical binding is different. One, exchanges a hydrogen ion, that's the covalent binding, and the other is kind of a more distant, softer binding and way it inhibits. So it's interesting. And now we have a third experimental, which is the degrader, which doesn't inhibit at all, but actually tags it and then chews it up. So there is no BTK until the body grows it back. Let's talk about other medications that come up, and that is headaches is a common side effect. It's common anyways, common with the acalabrutinib. Can you take Advil, ibuprofen, if you're a CLL patient? If that, a lot of people say Tylenol doesn't do it for me. When I have a problem, ibuprofen works for me, or naproxen sodium. Can you take these non-steroidal anti-inflammatories if you have CLL?
Generally speaking, we do tell you not to. But that said, once in a while, yes, we usually say it is okay. We know that some patients just don't respond the same with Tylenol. Pending your platelet count, right? We want to make sure your platelet count is safe. We do know that an occasional dose of one of these drugs should be safe for you. Again, not every day, but you also have to discuss this with your provider. And then we also know that, with the headaches with acalabrutinib, caffeine works really well. So even if you are not a coffee drinker or a tea drinker, there are caffeine pills you can try, which can help.
Yeah, I don't drink coffee, but I take these awake chocolates, dark chocolates, which are delicious. and have the amount of caffeine in a half a cup of Joe. So that's my go-to if I'm dragging in the afternoon. That's my little inside secret here. Muscle aches and pains are common with all the BTK inhibitors. I remember having just terrible joint pains, muscle pains, cramps, everything. Do you have any tricks for that for your patients? And they did get better after several months, but they did get better. Any tricks you have for your patients with that?
Yeah, these are, I would actually say this is probably the hardest to manage in patients. These can be pretty debilitating. And yes, they're supposed to get better with time on treatment, but that said, that is not reassuring for someone who is, having a hard time right now. So we usually tell patients to stay as active as they can. They can try some tonic water. They can try some magnesium supplements sometimes. And there are actually times where we've had to give patients a short course of steroids even, just to try to break the cycle. And those are usually our most common tricks, depending on how severe the joint and muscle pains are for patients.
Yeah, I found the magnesium tremendously helpful for myself. If you're going to take, do you have any concerns about the quinine in the tonic water and checking platelet counts and stuff like that? Is that a concern, or is that the amount so small that it doesn't really matter?
Yeah, I think the amount is so small usually that we don't. But again, we know we're monitoring the blood counts anyway. So, but I think, having some tonic water at bedtime, for example, is not going to be anything significant as far as the blood counts.
So here's one I'm going to take. This is an unfortunate caregiver who they're caring for. The person they're caring for has CLL, I assume, and also is getting radiation and chemo for lung cancer with positive PET scans, and asking about the life expectancy. And generally, when you have a second malignancy, especially a more aggressive malignancy, the CLL is not the issue. You take care of that other cancer, whether it's ovarian or breast cancer or prostate cancer. Generally, you take care of that other cancer first and then worry about the CLL. Usually it's that second cancer that needs the attention. And even though chemo doesn't work, sometimes it does work. I mean, even these people who are getting treatment for lung cancer can see their CLL shrink in response to that. Anything you want to add to that? Because we do see a lot of second cancers with people with CLL.
Yeah, again, the priority is always the more aggressive cancer. And we do know that there is a lot of crossover with some of these drugs, and that some of these drugs will also help with the CLL, even if just temporarily. So you might see a little bit of a response. But, again, with these secondary cancers also, we're just, we always want to make sure we watch the blood counts, and we also kind of supervise a little bit.
And here's a follow-up on this. It's related. This is a patient who's a CLL transformed to diffuse large B-cell lymphoma. So I'm going to ask you to explain a little bit about that in a minute. They had 6 cycles of R-CHOP, and I'll ask you to talk about that. Complete remission, wonderful, 10 months after R-CHOP. Blood work is all in the normal range, except my lymphocytes, which are 5.3. Here's the questions. What does this mean for my CLL, and what does it mean for the immune system? So maybe you can explain what diffuse large B-cell lymphoma is, what R-CHOP is, and answer this patient's question. Yeah.
Sure. So, as we talked about a little, CLL can transform or change to a more aggressive lymphoma, most commonly to a diffuse large B-cell lymphoma, though rarely it can also transform to a Hodgkin lymphoma. And so once you have a diffuse large B-cell lymphoma, this is treated differently and is treated with regimens such as R-CHOP for 6 cycles. So this is chemoimmunotherapy. Because it's more aggressive, this works. And so if we get your Richter's transformation or your transformed disease, the goal is cure. If we get that cured, you still go back to a state of CLL. So we didn't, though it worked on your CLL for a time, we know you still have CLL and your CLL is there. And you're saying your absolute lymphocyte count is over 5,000 still. And so that was our goal, to get you back just to a state of CLL. Your immune system is as strong as it is when you have CLL at baseline. Right, so we know that you're still immunocompromised at baseline. We know that diffuse large B-cell lymphoma is gone. And so you're going to take the same precautions you always would having CLL.
And the chemo is very hard on your immune system when you're on it, but after it wears off, it's not. The one that'll hang around is the R in the R-CHOP, which is rituximab, which will suppress your immunity for 6 months, 12 months even. So let's talk about that, because what rituximab and obinutuzumab do is deplete it. They don't only attack the bad cancer cells, but the good B cells, and those B cells make antibodies, and that's why we don't get responses to vaccines. First, tell us what a B cell is and what its purpose in life is, and how is it that we can get by without them if they're so important? Because a lot of us take these drugs. I'm on epcoritamab. My B cells are not measurable right now, which I take as a good thing, which means if my B cells aren't measurable, my CLL isn't measurable, so, but I'm walking around with no B cells and I seem okay. So, and lots of people are walking around with no B cells on rituximab or obinutuzumab or in clinical trials. So talk to us about what a B cell is and how is it that we can get by without them if they're so important?
Yeah, so your B cells are basically your infection fighting cells. They're super important. We know that CLL and SLL is disease of the B cells, right? And so they're really important for fighting infections. The good thing is we also have T cells, which fight some infections as well, right? And so we have previous vaccines before depletion of B cells. And so our body kind of comes together to try to put some kind of protection in place despite depleting these B cells. And yes, when you receive these monoclonal antibodies and and other therapies, other targeted therapies, we deplete your B cells. It is very hard, and that's where it becomes important to try to give yourself the best chance of protection. And we know with the monoclonal antibodies, unfortunately, the vaccines aren't really going to work. We really try to vaccinate people before they start to try to give them the best chance. But yeah, so the B cells, so your B cells are your infection fighting cells. And unfortunately, we do deplete those. Thankfully, there's T cells, and thankfully, your immune system kind of tries to rally and use your T cells to help fight infection.
Someone asked a question about the efficacy of LOXO 305, and I'll answer that easily. LOXO 305 is the old name for pirtobrutinib, and you heard about it, and it's extremely effective drug. I think this is an easy one. Should ibrutinib fail and pirtobrutinib is used next, could the patient go on to obinutuzumab and venetoclax?
Absolutely.
Yeah.
Absolutely.
Okay.
Completely different regimen, different drug class.
Uh-huh. All right. Here's I've been in remission for 8 years on a clinical trial treated with ibrutinib. Rising lymphocyte and white count caused me to take an off last week. Wondering about next medications and treatments. I think that's one that's also lots of good choices there. So you want to take that one because that's pretty common. Eventually, one of the things I try to teach people is that we have to think of all therapies as palliative, not curative. There are certainly exceptions, but most people will eventually relapse. So you've got to be thinking about this like a game of chess. What am I going to do now? What am I going to do next? So what do you do when that patient comes in and it's clear that maybe not today or tomorrow, but soon they're going to have to switch therapies? Talk about that discussion you have when they're coming off a BTK inhibitor or a covalently binding BTK inhibitor.
So yeah, so usually we try to clue the patients in when we start to see them slowly progressing, just so they know. It doesn't mean they have to come off their drug right away, but we are closely monitoring their disease, and we'll start to talk about treatment options, not just the next treatment option, but the one after that, right? Everyone should be sequencing in their head at all times. That might change based on what becomes available and what clinical trials. But so usually if you're coming off a BTK inhibitor like ibrutinib, it's not for side effects, you're progressing, then the next line of treatment would be a clinical trial, whatever's available, or you would get venetoclax and rituximab, which is time-limited therapy for 2 years. So that's usually the way we look at it. So we would look at the venetoclax-based regimen and or a clinical trial, depending again on what's available for that patient.
And I would add pirtobrutinib to that list too now, depending on what those markers are, try to get that off label for the patient.
Yeah.
And I would push a little bit. I like venetoclax with obinutuzumab, again, off label, second line, but if they've not had it before, I think that's a more potent combination.
Yeah, true.
So a couple things that come up: alcohol with CLL in mixture with drugs, and medical marijuana with CLL in mixture with drugs. I'm sure you get asked this a lot. So how do you respond to those questions?
We usually respond with A drink here and there is okay. Be careful, okay? It's New Year's Eve, you want to have a glass of wine, perfect. We do not enforce continuous or daily drinking. There are interactions with your medications. Medical marijuana, there can be some benefits to patients, especially patients having side effects. We strongly advise against smoking marijuana, anything chewable, or, I don't even know the methods anymore, but anything that is not smoked, because when you smoke it, there are spores, right? So now you're putting yourself at a higher risk for lung infections, especially fungal pneumonias. So we really want to avoid people smoking. Other than that, I do advise, though, that you speak directly with your oncologist and your team to see how they feel about it, and so they can look at exactly what regimen you're on.
So while we're talking about things outside of the normal treatment, somebody asked about mistletoe, and I'm amazed that we haven't got a question about green tea extract. We always get that. So I'm in watch and wait, which I prefer to call active observation or active surveillance. That's what we call it in prostate cancer and other diseases, because it suggests rather than being passive, you're involved in the care. Mm-hmm. Are there things that I can be doing? Are there supplements I can be taking? Are there diets, exercise, lifestyle changes I can be making? Because it's a kind of tabula rasa. It's an open, we don't know what's going to happen with watch and wait. Some people, 20-25% of people never need treatment. Maybe I'll be one of those lucky ones. Yes, the prognostic markers suggest whether I'll be lucky or not, but they don't apply to everyone, So what do you talk to your patient? Because this is one of the most common. What can I do, doc? You told me I have cancer. You're not going to treat it. So what am I going to do? So when I come in 3 months or 6 months from now, you're still not going to treat it.
So we just say to really just try to be as healthy as possible. Well-rounded diet, routine exercise, stay up to date with your healthcare screenings, make sure everything else is in place, give yourself the best chance, get your vaccinations. And, there are some supplements that patients do like to try. And, when you're in watch and wait, that's okay. When you need treatment, there might be interactions, and that our opinion on that might change. I know a lot of people like to try turmeric and green tea. Again, in trials with green tea, the dosages were super high that were used, and there was some GI intolerance. But there are patients who do believe strongly in supplements and strengthening the immune system, and that's completely okay with us. But from our standpoint, well-rounded diet, healthy exercise, try to stay in the best shape that you can.
The green tea extract that was used is no longer commercially available, and it was a huge dose, 4 grams of EGCG. Mayo is talking about bringing those trials back again, and it did have some effect, but it wasn't, bluntly a dramatic effect in my read of that. But I agree. I mean that generally a Mediterranean, the kind of diet you would take for your heart is going to be good for your cancer. It's just, a Mediterranean diet and a healthy diet and regular exercise. Study after study has shown that exercise, especially if you can get your heart rate up and you want to clear with your internist or cardiologist or family doc about that, that seems to really make a significant difference in improving immunity and can help. Talk to us about MRD. First, explain what MRD is. I like to use the word measurable instead of minimal. How is it defined? There's confusion about the definitions, -4, -6. Is it something that you're using? Is it only in clinical trials? This is a big topic at IWCLL. And when you got a patient in front of you, talk to us about MRD. First, explain what it is exactly and how it's measured, and then explain what you, as a clinician, how it's important to you and your patient.
Yeah, so simply stating measurable residual disease is, can we test your blood and find, or your bone marrow, and find any signs of CLL? And it can be measured at different levels of acuity, I guess is the way to say it. And so when you're in a clinical trial and they're measuring it, they'll usually define exactly how that test is done. But so usually for people who are on continuous therapy, we do not routinely check for minimal residual disease or measurable residual disease. And people who are on time-limited therapy, once they have completed their therapy, we will check, because that's the point. We know that they can actually reach undetectable, measurable residual disease. And so that basically is saying that either we will just test your blood work or we will test your bone marrow, and we will see if we can detect your CLL in any capacity. And then there's some tests that are super sensitive and some are kind of basic. And so that's what we'll do. And we'll see if we can detect your CLL.
Yeah, there's different ways it's measured. The classic way is flow cytometry, which is the way your CLL is diagnosed, and it can test down to 1 in 10,000 cells. And there's some fancier tests, next generation sequencing, specifically clonoSEQ, which is a brand, which can look down to 1 in a million. Mm-hmm. And these are being investigated and may play a significant role in the future in determining when can I stop therapy, when does my therapy need to be amplified. I think that this has a future role. Right now, it's mostly being used in clinical trials, but I think it's very helpful. Mm-hmm. Here's somebody asked me about the cost of the drugs, and is that part of the medicine cabinet? It isn't right now, but let me just say, they're all really expensive. None of them are cheap. Essentially all the BTK inhibitors are 10,000 plus a month. And venetoclax is in that same range. And the antibodies are in a different part of the insurance, but thousands to several $1,000s. The drug I'm on commercially, epcoritamab, I understand, is $37,000 for an infusion. So these are not inexpensive drugs, just to be aware of. And that's why it's important that we look at ways to be controlling this, and we'll have much better control beginning next year and even better the year after. Related on that, somebody asked about the Inflation Reduction Act and ibrutinib being listed there. And I think this is a very complex circumstance. And what we do want to do is make sure these drugs are affordable. And now that we have a cap in place for Medicare patients, we can be sure that the greatest out-of-pocket expense for these patients, not immediately, but soon, will be $2,000 for anybody. That's no matter how many drugs. If you're on a combination of drugs, it'll be $2,000 out of pocket. So once that's in place, that's really important. How they pay for that, I don't want to be on the back of ongoing research for rare cancers. And it's complicated, and there's a lot of sides to these stories, but we want to make sure that the costs savings are not disproportionately affecting the rare cancer community. And CLL is a rare cancer. And there's a lot of concerns about the way these cost changes will be implemented that the CLL Society is addressing. And you can look at our Policy Institute in terms of that. So here's an oldie for you. I don't know. You said you've been doing this for more than a decade, so maybe you know this one. R squared, Revlimid and rituximab. Is that one that you have any familiarity with? Somebody used it for a while and then switched to ibrutinib. I know of a handful of patients who are still on that combination and doing well. Can you discuss what that is? Or
yeah, I am not overly familiar with that. There are a couple patients before my time who I know were on that regimen for quite some time. And I know we have a couple of patients with follicular lymphoma who are on that regimen. But as far as CLL, I don't have that much information on that combination. I'm sure you know more than I do.
So let me share a little bit. Revlimid, or lenalidomide, is a immune modulating drug, which is kind of a hand waving definition saying we don't have any idea how the heck it works. I mean, let's be honest. But it is quite effective in CLL. But it also has significant adverse events. And some trials that were run, there were deaths because it can cause the tumor to flare at the beginning. It stimulates the immune system. The cancers would swell up and cause respiratory problems and other issues, and there was death. And the company that made Revlimid decided not to go forward with CLL research. And that's one of the reasons this area is moribund now. But it is an effective drug, and it's sometimes when we're head scratching and we're saying, what are we going to do with this patient? They've had BTK, they've had they've been on a couple clinical trials, they've had venetoclax, we're running out of options. Sometimes we'll pull up Revlimid and patients will get responses, and it's often used in combination with other drugs. So it's still an option to think about, and there are other drugs that are being developed in this area, so it's still part of the picture, though a small part. Somebody started on acalabrutinib 6 weeks ago, developed a cough, a dry productive cough. Is this something you see with acala? And they're worried, could lung cancer be a second cancer? The answer is yes, lung cancer could be a second cancer, but it's not the first thing that would jump into my head if I got a cough, so yeah.
Yeah, this time of year, I think I would probably just make sure to rule out an infection first, or allergies or anything else. We know you can have an increased risk of infections when you're on therapy, especially acalabrutinib. And so, I would rule out other causes before I would assume it's the drug itself.
So someone asked, do any treatments lead to remission? And I think what they're asking is a little bit of a different question, because all treatments can lead to remission.
Mm-hmm.
Remission just means the disease is under control. They can be partial remissions, complete remissions. You can get to undetectable, measurable disease. What about curative? Do any treatments have the potential to cure the CLL? And we talked about, I said all therapies need to be thought of palliative with some exceptions, but there are some exceptions. You want to talk about that a little bit?
Yeah, so a bone marrow transplant itself is really the only cure. And again, it's not something to be taken into lightly. It is not something given in first line, even second line. It's something we look at kind of later on when patients might transform to a more aggressive lymphoma, patients who are running low on options. And again, that is because you're literally replacing your immune system with the immune system of someone else who's healthy. And so that is really right now the only way to be cured of CLL.
There are a couple other things I would add to that. There's a handful of patients with all the best markers, young, healthy patients who received FCR more than a dozen years ago now, and who are still have no measurable disease. That smells a lot like a cure to me, but it's a very small percentage of people, and people are looking at that and seeing if that can be done. So some people are cured with chemoimmunotherapy. So that is something. Neutropenia, somebody asked about neutropenia. I would point out that venetoclax and obinutuzumab can cause neutropenia. That's common. Is neutropenia an indication for therapy? You talked about therapies, yeah.
So neutropenia can actually be an indication for therapy. We know that a lot of these drugs can knock your absolute neutrophil count down, and that is when you are neutropenic. So some patients who are persistently neutropenic might just need therapy. Others might be neutropenic from their therapy. And at that time, we can support patients with growth factors like pegfilgrastim or filgrastim, which are injections that help bring your white blood cell count up faster. We can support patients when they're neutropenic sometimes with prophylactic antibiotics if it's persistent. And a lot of times, yes. So especially if you're on venetoclax and obinutuzumab, the combination of both those drugs together just puts you at a higher risk of neutropenia. We know they both can do that. We know patients do struggle a little bit, and sometimes we have to support through. And then once they get through the obinutuzumab portion and their venetoclax dosing is higher, sometimes we do see improvement in the neutropenia.
Beta-2 microglobulin, B2M, people asked about that. Is that something you use as part of your clinical practice?
Not routinely. We do check it when we have new patients. We just want to see, it's a kind of a marker of, the higher it is, right, the more aggressive your disease. And so we usually check it in the beginning when we first meet a patient just to see where our baseline is, but we don't routinely monitor the beta-2 microglobulin.
Somebody asked about behaviors to reduce the chances of Richter's, and I wish there was something you could do, but I don't think so. I just have to share this with you. Dr. Nicole Lamana, who I think you know pretty well, said, "Amazing job, Christina." Yes. So in the comments. So yeah.
Thank you, Dr. Lamana.
Yeah. So we're just about oh, here's one important question, real important question, and then I'm going to ask you to summarize your thoughts so we can close up here on time. The cardiac effects.
Mhm.
We know that the other effects go away when you stop the drugs. What about the cardiac effects? If you got atrial fib, you developed it on ibrutinib, does it stop when you stop? If you have hypertension, does it get better?
So, so technically, if you stop your BTK inhibitor, and the BTK inhibitor is the cause of your hypertension, you would think that your hypertension would get better. Now, there is no guarantee on that. That's something that would have to be monitored closely. Patients who did develop an atrial fibrillation or a heart arrhythmia are most, unless they were, cardioverted, or they were, they've never gone back into, the rhythm again, might be on medications for life. It really depends on, how did their arrhythmia recur, how well is it managed, and that would be something we would actually recommend they follow with a cardiologist for. But for the most part, I would say the hypertension would probably at least improve. The arrhythmia will always be in the back of your mind as something that would need to be monitored.
Yeah, and certainly I've seen it both ways. I've seen patients who have persistent atrial fibrillation after they stop therapy, and I have seen patients where it does get better. So it's unlike, we can pretty much guarantee that the arthralgias and the bruising and those things are all going to, the dry eye, all of that stuff goes away. But the cardiac stuff doesn't always go away, to be honest. And I think that that's an important consideration to think about. There's a billion other questions here. Let me just add one. I'm not going to squeeze one more in, because I want to give you a couple minutes for any final thoughts you might have that you want to share on, treatment and how to approach CLL and what you do with your team, and any advice for patients in this very involved and complex. And I'm very grateful for everybody's questions. And if we didn't get to them, we can get to them through Ask the Expert. Yeah.
Yeah. So again, thank you so much for having me. I know this was super brief overview. We could talk for hours on treatment options and side effects. And so the way our practice usually does it is, once we have spoken with the patient and had a powwow about exactly what the best therapy is, and everyone's on board and everything's planned out, we do educational visits via telemedicine with not only the patient, but their support system, which is super important. And we go through kind of all the details, all the protective medications, all the prophylactic medications, and kind of the whole plan before we start the therapy. And then we'll start the therapy together. And patients get treatment calendars. And the biggest thing I can recommend is that if you are undergoing treatment and you have questions, you have side effects, you're just not sure, you really need to feel comfortable reaching out to your care team. This is a team and you are part of that team. You are a very important part of that team. And so the communication has to be there. If you do not feel comfortable doing that, then I would recommend that maybe you investigate another care team. It is very important. This is your life and your therapy. But that said, CLL, the landscape, the treatment landscape is constantly evolving. It's really exciting right now because there are so many drugs in development. And the last 10 years have been a game changer. And, patients are living so much longer now and doing so much better. So it's a really exciting time for our patients. But again, yes, thank you so much for having me. And remember to be an advocate for yourself.
Christina, this was amazing. Well done. Lots of questions. We got through a lot of them, so we did pretty good. There's a couple things I would add. Consider a support group. There's things that another patient can tell you. When a patient tells you about their infusion reaction and how they got through it, that's so much stronger than, bluntly, when a healthcare provider tells you about it. When you can meet a patient who's had CLL for 20 years, those kinds of things. So think about support groups. The CLL Society has 40 plus across the country. And the other thing is, I'd say educate yourself by attending these kinds of webinars and stuff. I did want to thank our generous donors in the grant support that we received from AbbVie, AstraZeneca, and Genentech, without whom this wouldn't be possible to put together. Please take some time to complete our post-event survey. It's really helpful. There's the link, asktheexpert@cllsociety.org. If we didn't get to your question, our next event is a Facebook event, which is Ask Me Anything. And these are a total kick. There is no lecture. We spent a lot of time on questions and answers, but this one, this is anything you want to throw at Dr. Parikh. And if you haven't heard him speak, he's a fabulous educator. He's out of Mayo Clinic and stuff. So he's just great. Thank you all for joining us, and especially thanks to Christina Russomanno. She was great for her presentation. Please remember, CLL Society is invested in your long life. You can invest in the long life of CLL Society by supporting our work. Together, we're going to improve the lives of those with CLL and SLL. Again, thank you for your participation. Thank you for attending. And a big thanks to Christina and to Robin for their hard work on this. Thanks so much.